Hi, everyone, and welcome to this episode of Arthritis at Home, which is hosted by arthritis consumer experts. My name is Cheryl Koehn. I am part of the leadership team at Arthritis Consumer Experts, and I could not be happier to start off the year of my interview assignments with Dr. Stephanie Keeling. Dr. Keeling, thank you so much for taking the time to join us this morning.
Oh, my pleasure. Thanks for having me.
Let me tell our audience a little bit about you in this episode, which is really focused on the latest on lupus treatment and care in Canada. Dr. Stephanie Keeling is a professor in the Faculty of Medicine and Dentistry at the University of Alberta, which is in Edmonton, and a member of the Lupus Working Group. The Lupus Working Group consists of lupus specialists from across Canada, along with two national patient organizations, the one I'm privileged to work for, Arthritis Consumer Experts, as well as our partner in this advocacy endeavor, Lupus Canada. Dr. Keeling is a former board member of the Canadian Rheumatology Association and is a current member of the Guidelines Committee, a very important group working on best practice, best evidence guidelines for arthritis. She's also the treasurer of the Canadian Network of Improved Outcomes in Systemic Lupus Erythematosus. That is a mouthful, Dr. Keeling. We like to call it CANEOS. Which is a Canada-wide group of rheumatologists who do focus on lupus, collaborating to study Canadian SLE patients and Lupus Clinical Investigation Network, LUCIN. So you're everywhere, Dr. Keeling. LUCIN is a North American network of rheumatologists who are working to improve the lives of patients with lupus. And it doesn't really matter where you live in the world, lupus is lupus. So we're going to learn more about that. Dr. Keeling is also the principal investigator of grade-based recommendations for the diagnosis and management of lupus in Canada. So she's particularly interested and expert in lupus because it affects the whole person. And we're going to hear about this in a minute. That's the physical, the cognitive, the emotional, and the social aspects of a person's life. And from person to person, it can affect people in very, very different ways. Dr. Keeling's research aims to discover ways to diagnose lupus early in its development and to ensure that all lupus patients receive consistent, high quality, effective, and timely care. So all about equity, which we love here at ACE. So with all of that, our esteemed guest joining us today, Dr. Keeling, let's just dive right in to some questions about lupus, about your work, and about what you see as sort of a path forward. So to start us off, can you describe for our audience sort of what the two main types of lupus are that affect people that you see both in your clinic and in your research work?
Absolutely. They call lupus the disease of a thousand faces for the reason that you could have five people with the same diagnosis, but very different journeys, different manifestations. In general, and this is also how we kind of target our medications for it, we think about systemic lupus, and then we also think about lupus nephritis. So those would be arguably the sort of main subdivisions. Lupus is a disease where the immune system is attacking parts of you. And it's complex, but one of the simple concepts is your antibodies, instead of fighting infection, they're fighting your tissues, causing damage. So people with systemic lupus, it's not a rare disease, but it's not super common.
Right.
I would say, in Canada, the stats are old, but we think there's about 1 in 1,000 Canadians, roughly. It might be a bit higher, who actually have had a diagnosis of lupus.
Yeah. Who gets lupus?
Excellent question.
I
Anybody
mean,
can get
typically,
it.
I know there's no typical, but
Yeah.
typically, who gets lupus?
Well, I would say it's predominantly a disease that affects women, like 90% plus affects women than men. And the other, it really affects people, whether you want to use the term our BIPOC population, so Black, Indigenous, and people of color. So there is a significant prevalence of it in many of our like visible minorities and so on.
Right. Can you explain? This was when I first was diagnosed with rheumatoid arthritis, and then I learned that lupus was a type of arthritis.
Yeah.
why is lupus under that big umbrella word arthritis? I mean, sometimes it is and sometimes it isn't. In fact, now specialists who look after people who are living with lupus are called lupologists.
Yeah.
So explain where lupus fits into the arthritis picture or vice versa.
Yeah. Well, I'm glad you asked that because I
Yeah.
think by the same token, the arthritis consumer experts have been amazing at advocating for lupus. Similarly, the Arthritis Society. But how does that fit in? Well, we know that one of the biggest manifestations of lupus is the arthritis, so inflammation in the joints, and this can lead to various kinds of deformities. So it's not like rheumatoid arthritis exactly or psoriatic arthritis. I'd call it sort of a cousin of it. Some of the ways it happens, if you're talking about it science-wise, is slightly different, but it's one of the most common manifestations of lupus. Whether or not you have the other stuff, as I said, you can have lots of different variations, but inflammation, arthritis is a really common manifestation of lupus. So that's why people who advocate for arthritis conditions do include it.
Right.
Yeah.
So when I hear you and I heard you say at the very beginning describing lupus that it is an autoimmune response that attacks tissues, that's not necessarily tissues in the joint versus tissues like organs.
Yeah.
So that is sort of broadly speaking a big differentiator between the two.
Yeah. Well, we know it can cause obviously damage in the joints, but we
Yeah.
know similarly, like I didn't really mention that before, but many air organs could be fair game. So that could be anything, and that the common one is the kidneys. So
Yes.
roughly a third of patients might have lupus nephritis, which is the official terminology. But occasionally it affects your brain. It can affect your lungs, your heart, or the lining of those. Skin is a really big manifestation. So there's a whole slew of different rashes that people can get.
Yes, butterfly rash, I think that
Yeah.
we hear about. Yeah.
Yeah, that's the most common one, but there's a whole bunch of other ones as well. We share a lot of our care with our subspecialists, so dermatologists, nephrologists, and so on. And
Okay.
even like your red cells, your platelets, your white blood cells, those can also be affected. And the mix of wood organs can super vary between some people with the same diagnosis.
That's great. That gives us a sort of a big macro vision of what lupus is. We're going to provide some resources at the end of this video as well, so that people can go and read more. I mentioned when I was introducing you, Dr. Keeling, that you're part of this lupus working group. And you were the lead author on a piece that was published in the May 2024 issue of the Canadian Rheumatology Association journal that really looked at inequities in people who are living with SLE in particular, the things that they're facing and accessing life-changing medications based on where they live, which isn't the premise of our universal healthcare system. It shouldn't matter where you live to get high quality, affordable, and timely care that is based on current clinical guidelines.
Yeah.
So thank you for writing that, because it's become a bit of a standard bearer for our working group, saying this is about equity. And currently there are patients in our country who are facing inequity.
Mhm.
Um, can you tell us more about that article? Like what was it that caused you, besides we forced you to put your hand up in the air and volunteer to write it, but really you were so, I don't want to, sometimes the word passionate is a bit dismissive. You were like a dog with a bone with this article. So tell us about that.
Sure. So, sadly, the circulation of the Canadian Rheum Association Journal is really target audience tends to be the rheumatologists, although we would love to disseminate it everywhere. So this is a great example of that.
Yeah.
Um, I mean, this could be a very long story, but in brief, um, we know that a couple biologic drugs had received Health Canada approval. So the main ones would be, for example, belimumab,
Yeah.
and then anifrolumab. So those were coming out, and the complexities of drug approvals in Canada, I think, is also part of the problem, but beyond the scope of what we're talking about today. But what we know is that um, we were seeing that as we heard these drugs were going to be considered for public listing per province and territory, and then organizations like NIHB, we were already seeing concerns that given there was a what's it called, a precedent that was set with the original biologic belimumab, where even though it was approved in Canada, it never received what's called a positive drug review by a group that the provinces look highly towards. Is this thing called CADTH, Canadian Agency for Drug and Technology Health Reviews. And because this group said a negative review, all the provinces tended, for the most part, each province decides if they're going to list it. So that's part of the problem about the equity, is that even if Ontario says yes, doesn't mean Alberta or BC or Yukon is going to say yes.
Yeah.
And so there's a lot of heterogeneity there. So we saw already the problems that we had this drug belimumab for over a decade, but very few rheumatologists have gotten their hands on it to try and hopefully improve the lives of our patients. So as we were seeing this other new drug called anifrolumab potentially going to be reviewed per provinces, a lot of the rheumatology colleagues, I could name them all, people probably might recognize their names, they're amazing, all across the country, advocated even at the level of CADTH, and included also integrating what happens to us, to those patients with it. And essentially, I think helped facilitate that positive review. But even still, all last year, we were waiting and saying, will Alberta list it? Will Nova Scotia? And so on. So at that time, we were seeing patients in our clinic where we know the data for this drug is so good. We see our colleagues in America, in European countries having access. We're hearing all of it. And all we're doing is we're using prednisone steroids, which are life-saving for patients, but it long-term is not life-saving. It actually can reduce life expectancy and cause a lot of damage. And we don't have a great toolbox of existing immunosuppressants or antimalarial drugs. So it was very frustrating. And so a lot of the colleagues, we all kind of got together and said, we need to, I think part of the problem is if you pit the arthritis of lupus and all of its manifestations against other, I don't know if you want to say sexier diseases that have more, I think, face value, more people in the general population understand it better. That's part of the problem. We also know we have a lot of patients I was seeing in clinic were Indigenous patients who were not getting access. And, I had one die last year and it was pretty devastating. I mean, a lot of us have similar stories, or people who, are mothers or students or can't work because of the damage of the existing drugs or their disease. So yeah, so that's kind of how that came together, with an attempt that we can make awareness greater at, like you say, like the general public, the government levels, provincial, municipal, and obviously federal.
Well, it clearly made a difference, Dr. Keeling, because now the second one that you spoke about, anifrolumab, which patients would know by the name of Safnello, does enjoy public drug plan reimbursement pretty much across the country. There's still a few spots that need to act. But I think what you describe is the classic condition of inequity between patients, um, and also equity sometimes relies on where drug budgets lie. So for in cancer care, they largely lie in the institutions versus the public drug plan writ large. So kudos to you, to your colleagues, to the patient organizations, including ours, that are fighting the good fight and continue to win equity for people who are living, and many who are struggling with lupus. And it's been years. There's basically been no new development in lupus treatment. And that's where we go next in our interview with you. So you've described these two medications. One has been around for a long time. Another one is new to the marketplaces. But along with those medication treatments, what else have you seen change for the better in terms of lupus treatment and care, specifically in Canada, Dr. Keeling, or has there been improvement besides these medications?
I think obviously the win of largely pan-Canada access to anifrolumab is a win. I actually still think we have a long way to go. to be unfortunate, to be honest. Like until we had access to these, we were doing. I think there have been some minor changes. I think the increased recognition because other guidelines, like in Europe and the States, recognize that steroids is we used to accept larger doses of long-term steroid for years, and I think making awareness of our colleagues in Canada that actually zero steroid, like zero dosing, it should be the target, not like a low chronic dose. That may be a little win, and that's I think making awareness of all our colleagues, not only in rheumatology but primary care is another one. And working with them, so maybe increased awareness a little, but there's still some other things that need to be.
Yeah. Yeah, we know that well and feel that pain for certainly for our fellow patients, our members that are living with forms of lupus where still many barriers exist for them. You know, the American College of Rheumatology meeting, which you just attended in November, it happens every year, like our own Canadian Rheumatology Association scientific meeting coming up next month in Calgary. They issued a new guideline for screening, treatment, and management of lupus nephritis. Can you tell us about that, how exciting that is, not just for the clinical community, but how it impacts on people living with lupus?
Right. Yeah, I think that the thing is, recommendations or guidelines may seem boring. And if you read them, you might, as a clinician or maybe as a patient, you may say, well, yeah, that's obvious. But it's the only, I think it's the best tool we have to show to the decision makers, right? For actually approving drugs, whatever country you're in. So that same applies to Canada. And so I think when we were sitting in the audience at the plenary when they recommended, they showed the highlights of the lupus nephritis recommendations. And I will say that the lupus SLE for general lupus is coming out imminently. And so over 2025, those are going to all be rolled out. A lot of the audience really appreciated these because I think a big key was they included children and adolescents. And
Yes.
that was new because that's always been, it's kind of like, it's always weird with pediatric rheumatology and adults where when they turn 17 years and 9 months, they can't go to the peds emerge in a lupus flare. They go to the adult. It's a sort of an arbitrary cutoff. And we know, a lot of some lupus starts in the younger ages. So that was, I think, a big win and
Yeah.
very important as well.
That's fantastic. Yeah, I had read about that myself, and that is super exciting because there's always been a bit of a chasm,
Yeah.
and especially in the area that we work mostly in, which is inflammatory types of joint disease, so rheumatoid arthritis, ankylosing, et cetera, et cetera.
Yeah.
People often lose their way. You know, people who are being treated in the pediatric system have a difficult time transitioning. Now, our partner and the leader in pediatric advocacy, education, information, Cassie and Friends, and I know there are others in the country
Yeah.
at the regional level, but Cassie and Friends have developed a number of terrific programs to help people through that transition. So we're going to give links at the end again to these new guidelines. We're excited to see the SLE guidelines come out, as I know are you and your colleagues here in Canada. And we'll also provide links to Cassie and Friends and other resources for continued learning. Lastly, we want to wind up with a question, Dr. Keeling, about your efforts to lead at the Canadian Rheumatology Association, the creation of clinical guidelines for the treatment of lupus in Canada. So
Mhm.
looking, now turning our focus from guidelines created and launched in the United States to those that are homegrown and
Yeah.
will be soon launched, I understand. When do you expect the publication of the guidelines? Will there be recommendations for children and adolescents in our guidelines, like in the ACR or American College of Rheumatology guidelines?
Yeah, it was excellent lead. And I would say what we were hoping to see, and why we're now going to update our guidelines, is we're actually going to leverage the ACR, American College Guidelines, because they are a very powerful body and they did amazing work. They use the same methodology. All of that to say, though, we need to do something. Officially, the term is adolopment, which essentially is like adopting and adapting and using trustworthy guidelines, but contextualizing them to the Canadian piece. So that
Right.
includes Obviously, we have the adolescent pediatric piece, and we did even on the previous Canadian recommendations work with our pediatric colleagues, I have to say, but we didn't have treatment guidelines. So now, because we have these new treatments, the biologics, it's a really vital, important time. And so over the next year, we are, as the ACR guidelines are rolling out, we are taking them, going to contextualize them because we don't have exactly the same population. We also don't have exactly the same funding system. It's more public, obviously. So we need to Canadianize these, and there will be specific considerations, to our other Indigenous populations and so forth that we need to consider. And
Yeah,
if you allow me just to say, I think the
absolutely.
important thing is knowing that we know, like all the lupus colleagues of mine, we are doing studies and trials of some amazing new therapeutics that should be coming that hopefully would one day get Health Canada approval and so on. And even a new amazing type of therapy called cellular therapy. Our worry, and that's why I think the guidelines are so important, is given the difficulty we've had just for these two existing biologics, and one of them, belimumab, even though you can get it now for the lupus nephritis, it's good for general lupus. It doesn't have a lot of public listing in many provinces. So, and there's no compassionate early. So there's a lot of, this is why I said we still have a long way to go. And that's
Right.
where, if we're showing the standard of care, it needs to be some of these new therapies as they emerge and we update the guidelines. We hope that will help with the advocacy at all the different levels when these drugs might be considered.
Yeah, Dr. Keeling, you kind of nailed it on the head for us in our own shop here at ACE. And I know I can speak for Lupus Canada as well. These guidelines are really foundational to the advocacy work and to the information education dissemination work that we do every day, day in and day out. It is your expertise and the expertise of the scientists that have been from the bench to the bedside, I should say, all
Yeah,
aspects of lupus treatment and care, that we really rely on to, it's actually a teaching process to government,
yeah,
right?
yeah,
Health policy makers can't be expected to be expert in everything. I mean, there are people that back in their own community were running an insurance business or, had an auto mechanic repair shop or they were a teacher or a banking executive. They're not necessarily experts in health. So we rely on what you're developing. We then put it into consumable language or reader-friendly language, and then together with you, we go forward to government and say, here is what should be taking place and being factored into the policy that you make that has a direct impact on people's lives. So we have just immense admiration for you, for everyone in the Lupus Working Group, for everyone who's taking care of people with lupus. We know there's a lot in what they call the pipeline.
yeah.
There are lots of new investigations going on. So thrilled to hear that you're a part of those clinical trials because it's important that Canadians be represented in those trials. Drug analysis or review really does factor in Canadian participation in these trials. So just massive thanks for you, Dr. Keeling, to you, to all of your colleagues, and for taking the time to sit with us today. Last word, anything else you'd like to share with the audience?
No, I actually think I appreciate having a platform and to recognize that I know sometimes, all doctors get that stereotype. They're so like we see beyond just the immediate rash or arthritis. There's so much more to it. I think it's never a good time to have lupus. I acknowledge that. But right now, the potential is exploding, and we don't want Canada to be disadvantaged to other G7
Or
countries.
left behind,
Yeah,
because when
and
Canada
there's
gets
that
left behind, its citizens get left behind, or the people that
yeah.
live here get
And these
left
are
behind.
productive people, who deserve the right when we know the therapy's there. So
Yeah.
I'll
That's fantastic. Thank you again, Dr. Keeling, for taking time out of your busy day. We're going to let you go, and you'll probably run off to see a patient. So we're going to let you do that, and wish you well. Happy New Year, I think, is still in order because it's January. And we look forward to seeing you at the Canadian Rheumatology Association scientific meeting.
Thank you. And given my background, Ukrainian New Year's is just coming, so happy early Ukrainian.
Perfect, perfect.